welcome to this session. Today we are going to look at components of labor and fetal assessment. And my name is Kiden Robina, and I'm going to take you through this session. So by the end of this session, students should be able to explain the importance of monitoring fetal well-being during labor, identify different methods of fetal assessment, such as fetal heart rate monitoring and the biophysical profile, interpret fetal heart rate patterns, and recognize signs of fetal distress. So, why should we monitor fetal well-being? We monitor fetal well-being so that we can identify potential problems before they escalate, before they become worse. And this can allow us to timely intervene to make sure that we save the life of the baby and of the mother. Then, another reason is to assess the fetal oxygen supply, vital for brain development and overall health. So we do this monitoring to make sure that the fetus is adequately supplied with um, oxygen at all time to make sure that its brain develops well. Customize care plans based on real-time fetal responses to optimize labor outcomes. So these are one of the reasons to why we monitor fetal well-being. Let us look at fetal assessment techniques. So for us to assess for the well-being of the fetus, there are two ways. We have external fetal assessment and internal fetal assessment. So let's look at the external fetal assessment. The external fetal assessment is done using tocodynamometer, or it can also be called the tocotransducer. So it monitors uterine pressure. This one is used to assess frequency and duration, but can also be used to determine intensity of the contractions. So it's mainly used during labor when the mother is in labor. It is in form of a belt that can be tied around the mother's abdomen. So it helps to monitor and see how many of the contractions are coming within a minute, and how long does it take before another contraction comes, or when the contraction comes, how long does it last. Also, we also assess for that. Then how strong are the contractions. This is when the intensity now comes in. So palpation must be used to assess the intensity. So the palpation can be done on the abdomen to determine the intensity of the contractions. The external fetal assessment also offers non-invasive monitoring, like what I have already talked about, the tocotransducer that is used for monitoring the frequency and also the duration of the fetal uh, of the uterine contractions. Then the palpation that can be used to determine the intensity of the contractions. Then let's look at internal fetal assessment. The internal fetal assessment is done using an intrauterine pressure catheter, or can be abbreviated as IUPC, which is inserted into the uterine cavity. This measures resting tone and the actual intensity. The internal fetal assessment can be divided into two types. We have the fluid-filled catheters, then the solid-tipped. So these provide accurate measurements of contractions, contraction intensity, and the uterine resting tone. More invasive, but preferred in specific situations, more so in situations where there is doubt about the viability of the fetus. This is when we can use the internal fetal assessment. Otherwise, in a normal labor, the use of the external fetal assessment is just enough. But if things now become worse, then we can use the internal fetal assessments, which involve inversions. Inversion meaning we are referring to the intrusion or the insertion of these catheters into the uterus to make sure that the contractions are monitored and how intense they are coming. All this can be monitored. So comparing external and internal fetal assessment, let's look at external fetal assessment first. So external assessment, it is non-invasive, does not require anything to be inserted into the body of the mother. Then it is suitable before and after rupture of the membranes. So this can be done whether the membranes have ruptured or they have not ruptured, and measures the frequency and duration but does not measure the intensity of the contractions. Might require frequent belt adjustments, more so in the process when the contractions go low or they increase, they may require that adjustment of the belt. Internal assessment, invasive, requires adequate cervical dilation. So these ones involve the insertion of the catheter into the uterus, and because of this, they will have dilated, to have opened adequately so that the catheter can be inserted. Provides accurate measurements of intensity and resting tone. So the intensity of the the contractions can be measured when the contractions have worn off during the resting time or resting period. It can also be detected that the uterus is now at rest. So, preferred in cases of prolonged labor or when monitoring with oxytocin. So, in cases where the mother has been given oxytocin, or in cases where the labor has taken long, it is very, very important that this type of monitoring of assessment is done. Requires proper insertion and zeroing procedures. So this requires someone who has knowledge in this procedure so that can accurately insert the catheter into the right position. Nursing management and care during labor is also very, very important. So let us look at Leopold's maneuver. What is the purpose of doing this maneuver? The purpose is determining fetal head position, presentation, and the lie. So generally, how is the fetus stationed in the womb? Where is the head facing? How is the baby lying? So these are the things that we are going to look at. So the procedure, this procedure requires to be performed between contractions, because when the uterus is contracting and you perform the Leopold's maneuver, you will not be able to feel the fetal parts because the uterus will be feeling hard and everything is just enclosed within the hard uterus, so you will not be able to feel anything. So challenges with obese women or excessive amniotic fluid, which is hydromelia. We talked about this during uh, antenatal. So this can become a challenge because in obese women, when there's a lot of fats that have been deposited under the skin, it will prevent the fetal parts to be felt. And also the same if the fluid is too much, which is known as hydrominance, it can make the feeling of the fetal parts very impossible. Proper positioning and relaxation techniques are very, very important when carrying out this maneuver. So the the first maneuver in Leopold's maneuver involves palpation and identification of fetal head or breech. So you palpate to find out, you search with your hands externally on the abdomen, you search to find out where the fetal head or the breech is located. So that is the first maneuver. When you're doing that maneuver, that is what you are targeting. Then the second maneuver is identifying the fetal back. So you now, after identifying where the head is located and where the breech is located, then you can now look for the back. Which side is it, is the back of the fetus located? This is very important. Then third and fourth maneuvers is determining the fetal part above the inlet. So after finding where the fetal head or the breech is located, then identifying the fetal back, the next thing is to determine the fetal part above the inlet, that is above the breech. Which fetal part is located there? Is it the fetal head, the breech, or is it an arm? So all this you determine. So physical assessment and care, comprehensive physical assessment. So the comprehensive physical assessment, this refers to the thorough assessment which is from head to toe, and this involves a review of the systems also. Then evaluation of labor progress to see how the labor is progressing. Then categories of for monitoring and documenting labor progress. That is the category 1, 2, and the 3. Then intermittent auscultation and the fetal monitoring. The intermittent auscultation basically refers to the listening to the fetal heart. So, in this case, when we talk about intermittent auscultation, we are looking at that taking of the fetal heart that you take after a stated period of time. Mostly the one that is well known to us in normal labor can be taken every after 30 minutes. Every after 30 minutes, we listen to the fetal heart rate and determine how it is. We still continue. Uh, we also have a gene examination. Information on it will give information on fetal presentation, position, station, and the fetal and the head flexion. So all this information we can be able to get it from vaginal examination. We also, during this time, we can also determine the membrane status. Are the membranes ruptured or they are intact? Then fetal and uterine assessment. So fetal and uterine assessment can also be done during this time using the Friedman graph of labor patterns. This will include the mean, prolonged pattern phase, protracted labor, secondary arrest of labor. All this will be included in that graph, which is known as the pathograph. It is the one that is used for monitoring labor. Previously, we had the modified WHO pathograph, which was by Friedman. Then there is another modern pathograph, the one that is currently in use. You can also take time and study it and see how it works. It is simpler than the previous one. Psychosocial and the cultural considerations. So when talking about psychosocial and the cultural considerations, we are looking at responses to stages and the phases of labor. How is the mother responding to this? How is she behaving during this time of labor? Then the role of support systems. Who is there to support her? Who is there to give her help in case she needs a further management that is not available at that center. What is going to happen? Is there someone to move with her? According to the culture, do they allow the husband to be with her, or should it be only a female person to be together with her? So all these come into consideration when we are talking about the psychosocial and the cultural considerations. There are some women when they are in labor, because they know that they are participating, the two of them, in bringing this baby into her life. They really want their partner to be with them, and yet others feel like they should not even look at the partner. So all these have to be put into considerations. Importance of preparation for childbirth. We also look at the importance of the preparations that are made for childbirth. Previously, we had looked at the preparations that are done uh, for childbirth, the kind of preparation that the woman is supposed to do, and what she has to put in place, both physical and social, everything put in place. So right now we are looking at when she was doing her antenatal, was there enough psychosocial preparation done to her? What things like what she expects during labor, the kind of pain she expects, and how she is going to respond to it. Were these all told to her? Is she aware about this? So these are the things that we also look at. Then understanding cultural considerations, including labor rituals, some of the things that are supposed to be done during labor. In some cultures, when someone is in labor, is not supposed to react in a way of maybe making noise because of the pain, and many other things. So these all have to be taken into considerations. Then fetal heart rate interpretation. So fetal heart rate, we look at the baseline, which is the normal range of between 110 to 160 breaths per minute. So fetal heart rate can change with gestational age. In most cases, when the fetus is overgrown or overdue, has passed the 4 hours, heartbeats. So these beats per minute can be sometimes considered with caution, uh, in consideration in reference to the age or the gestational age of the fetus. Then tachycardia causes and the management need also to be looked into. Tachycardia, here we are referring to heart heartbeat for the fetus, which is higher than 160 beats per minute. So this means that the baby is likely going into uh, distress. How do we manage this? So we have to put into consideration, in case this has happened, then we need to act immediately. Then bradycardia causes and significance. Bradycardia also refers to the heartbeat for the fetus, which is lower than 110. So what does it signify when this happen, and which action have to be taken immediately when this happens? So both of them, be it tachycardia or bradycardia, are signs that the fetus is really distressed. So the major thing, the most important thing is to make sure that the baby is removed as soon as possible. And the only way out here is to take the mother for cesarean section when if you are in a hospital setting. But if you're in health center setting, then you need to prepare for immediate transfer of the mother. Variability, short term and long term, can also be considered. So when we talk about variability, we are looking at the changes that occur, and those changes that are short term and those that are long term have all to be put into consideration. The short term may not have a serious impact, but the long term are likely to have serious impact, more so on the fetus. Then absent, minimal, moderate, and marked variability of the uh, fetal heart rate have to be considered. Now, when we are taking the fetal heart rate, we need to uh, put into consideration this. Is the heart beating? Is it there? Is it beating? Or it is not there? That is when we determine the absence or the presence. Then minimal. Does it beat but minimally? Is it weak? Then moderate. Is it not too low, not too high? Then marked variability and marked variability fetal heart rate. So all this we put into consideration. Is it something, when we talk about marked, is it something that calls for immediate action, or it is something that you can manage, that you can do some things, some few actions, and they can be alleviated. Then periodic and episodic changes. Then when we talk about periodic and episodic changes, the heart rate keeps on changing. There are times when maybe you can take when it is 120, then the next time you take it is 130, next time like that. So this can happen sometimes due to maybe the mother changing position, the mother moving around, and many other things. So take time to study and see which one really calls for immediate action and which one can be managed. Then variable deceleration if the heart rate is reducing. Maybe you first took it, it was 130, then the next time you took it is 125, the next time you took is 120, the next time you took it is 115, then it goes on reducing like that. Then you need to sense danger. Then decelerations, early decelerations, like for instance, we expect that during labor, of course, more so when the fetus, the labor is almost going into second stage, or when it's actually in second stage, the mother is about to deliver, the fetal heart rate may decrease, and that is normal because of the increased contractions. It can be normal, but if it decreases when it is early in labor, then it calls for alarm. Then accelerations, the increase in the heart rate. Then late decelerations, when it is what I've described about when it decelerates late, like in labor. So let us look at variability of fetal heart rate. Absent fetal heart rate, not detectable. Fetal heart rate requiring immediate medical intervention. So if you cannot feel the fetal heart rate immediately, you need to refer this mother to go for scanning to determine whether the fetus is still alive or is not alive. Then minimal variability, fetal heart rate range of less than 5 beats per minute. It is indicative of fetal sleep or distress. So if there is that uh, variability of like 5 beats per minute, you first took it was 100, 30, then this time you are taking is 125. It is not so much worrying. So it may be that the fetus is taking a snap or is distressed, but it is not so much worrying. Then moderate, like for instance, the change, the variability is now 5 to 25. This some is also considered normal. It could be because of something that has stressed, but it can be reversed. Then marked variability, fetal heart rate range exceeding 25 beats per minute. This suggests fetal activity or autonomic nervous system instability. So there is something wrong if the difference exceeds 25 beats per minute. For instance, you took previously it was 130 beats per minute. This time when you take is less by 25, then by more than 25, maybe it is now 110. From 130 to 110, that uh, is marked. It is beyond. So likely there is something wrong. Then periodic and episodic changes. Periodic changes, this is the cyclic variations in fetal heart rate related to fetal breathing movements, typically 2 to 3 cycles per minute. Then episodic changes, these are transient alterations in fetal heart rate due to fetal movements, due to fetal movements, maternal movement, or contraction. So this is what that simply means. It's self-explanatory. I may not need to put more words. Then let's look at variable decelerations. What are the characteristics? There's a transient dips in fetal heart rate, which lasts for less than 20 seconds, not associated with the contractions. Then significance can be benign or indicate fetal hypoxia depending on severity and frequency. So when we look at this, it means that there is, when we talk about uh, transient dips in fetal heart rate that lasts for 20 seconds, not associated with the contractions, meaning the mother is not having any contractions at that time, but um, when the heart rate for the fetus is taken, there is the deceleration. It is low. The heart rate is low, and it is low, lasting for less than 20 seconds. It is not associated with any contractions. The significance of this can be benign or indicate fetal hypoxia depending on severity and the frequency. So how frequent, how often this is happening during the labor, and how severe it is indicates whether the fetus is having any hypoxia or is just something mild and it will wear off. Then accelerations. What are the factors that can lead to accelerations? One can be fetal movement, arousal, or stimulation. More so when the mother has been administered oxytocin. It sometimes can lead to these accelerations. Well, what are the implications? A reassuring sign of fetal well-being, indicating good oxygen reserve. So when the fetus is moving frequently and there is some acceleration or just, let me say, increase in the heart rate a little but not more, it is a sign that the fetus is doing well and it is getting enough oxygen. Then late decelerations, The causes can be uteroplacental insufficiency, reducing fetal oxygen supply. So, in the late decelerations we are referring to when the fetus becomes dormant, does not move very fast or does not move frequently, and in addition, uh, the fetal heart rate when taken is a little bit low. That means that there must be some problem. So the nursing interventions that can be done, close monitoring of the fetal heart rate, then maternal positioning changes, because maybe the mother has lied on a side that does not allow the fetus to get enough oxygen. For instance, if she has lied on if the cord has been compressed because of the way she has laid herself, so this can lead to that. Then oxygen administration, oxygen can be administered to the mother. Potential need for intervention depending on severity and the duration. Then nursing process application, utilizing the nursing process, very, very important in this stage. You need to assess, diagnose, then you prioritize on what is very important at that time, then intervene and evaluate. Passage assessment, assess the pelvis, pelvic inlet, midi plane, and the out plane. All these have to be assessed. Then understanding the true and the false pelvis. Because if you don't understand them, you will assess, but you will not know whether the pelvis is really adequate or is not adequate. So when assessing, we normally look at the structure. Then we look at the ischospines. Are they prominent or they are not prominent? So there are many factors there that we consider to determine whether it is adequate or not. So let's look at fetal skull characteristics. The fetal skull is a dynamic structure consisting of three major parts. We have the face, the cranium, and the roof. So these bones are not fused, so that they allow the head to adapt as it moves through the birth canal. The sutures of the fetal skull, including the frontal, sagittal, coronal, and lambdoidal sutures, play a vital role in molding the skull's shape. Additionally, we will learn about fontanelles, the intersections of these sutures, and how they provide valuable information about the fetal position and the newborn's condition. So we shall look at all that. So fetal attitude and the lie. Fetal attitude is the position of the baby's body in the womb, how the baby is being positioned. That is what we refer to as the attitude. So the ideal position is the general flexion, where the head is flexed, chin is on the chest, and the arms are crossed over the chest, and the legs flex at the knees with um, uh, the thighs against the abdomen. So this is how we expect the fetus to to be positioned in the womb. This position allow for easy delivery of the fetus. Then uh, so this position is the one. This attitude is the one that is known as attitude of complete flexion. Then we look at the longitude or vertical line, longitudinal or vertical line. So we expect that in normal pregnancy, the fetus will be lying longitudinally. The long axis of the fetus is parallel to the long axis of the mother. That is how it should lie. Most common type of fetal lie, 99% of cases are the longitudinal one, where the long axis, the spine of the fetus is lying parallel with the spine of the mother. There is no crossing. This is how it is supposed to be. Then this allows for normal vaginal delivery without any complication. When we look at the transverse and the horizontal line, the long axis of the fetus is perpendicular to the long axis of the mother. So this will result to the fetus crossing across instead of the fetus being perpendicular or lying parallel to the mother's spine. It is crossing, and this is not safe at all. So fetal attitude is the position. Fetal attitude is the position of the baby's body in the womb, and the ideal position is general flexion, where the head is flexed, chin on the chest, arms crossed, and the crossed over the chest, and the legs flexed at the knees with thighs on the abdomen. So this is what we have already talked about. I don't need to explain more. Let's look at fetal presentation. Fetal presentation refers to the part of the fetus that enters the maternal pelvis first. It can be cephalic, where the head enters first, or breech, where the buttocks or feet enter first, or shoulder. So different types of cephalic presentations, such as vertex, sinciput, brow, and the first presentations are available. So this can also result from the head or or this can result from the cephalic presentation. Then we have the breech presentations, which can either be the complete breech or frank or fluent breech, and we'll understand this also more as we continue. But simply to give you some simple explanation, the complete breech is the one where there's complete flexion, but it is presenting with the buttocks. Then the frank is the one where it is having extended head or extended the neck. Then the footling is the one where the fetus is having the foot coming first. Fetal position and engagement. Fetal position refers to the relationship between the presenting part and the mother's pelvis. The common positions are the vertex, which we have already talked about. The baby's head is down, facing the mother's spine. Optimal position for delivery. This is the best. If the fetal position is the vertex one, which results from the complete flexion attitude, then it is the best for the delivery. Then the breech position, the baby's buttocks or feet are down. This is a mal position. So any position other than vertex position is considered mal position. So the only normal position in pregnancy is the vertex position. Breech position. Breech position occurs in 3 to 4% of pregnancies. Types of breech: we have frank breech, where baby's legs are extended upwards. Then we have complete breech. Legs are bent at the knees and feet are near the buttocks. This one is also good. Can be delivered vaginally sometimes. Then footling breech, one or both feet are down near the cervix. So this is where there is a problem. There is a problem. Then transverse lie, transverse lie occurs in 0.5% of pregnancies. The baby's long axis is perpendicular to the mother's spine. So C-section is the main delivery option for this kind uh, of lie. There is nothing, there's no miracle that you are going to do because the baby is across, and once it is across, there's no way the vaginal delivery will occur. Only cesarean section. Then let's look at less common malpositions. One is the occiput position. The baby's head is down but facing the mother's abdomen. The baby's head is down, but instead of the face facing the mother's spine, the face is facing the mother's abdomen. Then face presentation, the baby's face is down instead of the head. So instead of the vertex of the fetal head being down, it is instead the face that is facing down. Then brow presentation, the baby's brow is the presenting part. Instead of you are feeling for the posterior fontanelle, you will be feeling for the orbital ridges, and you'll be feeling the anterior fontanelle. So that is a brow presentation. Potential complications of breech presentation. There is increased risk of cesarean section. Umbilical cord prolapse can occur because the presenting part is ill-fitting in the brain, so the cord may end up escaping. Then premature birth can also happen. Transverse lie occurs in 0.5% of pregnancies. The baby's long axis is perpendicular to the mother's spine, and C-section is the main delivery. So other malpositions, less common malpositions, these ones I think we have looked at them. Potential complications of these malpositions. There is longer time in labor. So the mother takes longer periods of time when in labor. There is increased risk of instrumental delivery. Then cephalopelvic disproportion can occur, and the mother may end up losing the baby if not acted very fast. Station and presenting part. Station is a measure of the presenting parts relationship to the maternal pelvis, and is represented on a scale from -5, which is above the inlet, to +4 at the outlet. So station helps predict the timing of birth and when the presenting part is floating or ballotable. So when you do the Leopold's maneuver, you will feel what is presenting down near the pelvis. So then you ballot. Ballot is you place one hand on one side of the presenting part, then another one on the other side, then you try to push this presenting part. Does it feel like a ball? You push it from one side, then you try to catch it from the other side. Does it move freely? If it moves freely, then that means that it is ballotable. So right there we have this image that is showing the stations. We have started from -3. The -5 is the one up at the brim. So we have started at -3, -2, -1, then up to 0. So the 0 is when you feel the fetal head, the presenting part, let me say. because it may be breech. The presenting part is at the level of the isthiospines. The isthiospines are those protruding parts of the pelvis that are seen in their. So this then we move downwards. We move to positive 1, then positive 2, and then positive 3. Then from there, now the baby is ready to be born. As it moves up to positive 4, and the fetus is ready to be born. So maternal and fetal adaptation. Let's look at maternal adaptation. There's increase in cardiac output, that is the heart rate and the respiratory rates all increase during labor. Then there is also increase in blood pressure, gastric emptying time also increases. So during labor, the gastric emptying time increases. This means that when the mother eats during labor, likely the food may not be digested immediately. It will take time for that food to move from the stomach into the small intestine. Then there's increase in the white blood cell count, and the high urine specific gravity can also increase. Then fetal adaptation, there's a decrease in fetal heart rate during a contraction. There's increased intracranial pressure. Caput succedaneum can also be seen. So the pressure within the fetal head is increased. Within the cranium of the fetus is increased, and as a result there may be accumulation of fluids under the the skin, under the membranes. So when this fluid is accumulated under the membranes, then it can lead to what is called the caput successiona. But this caput can wear off if the baby is born. It can wear off slowly on its own. It does not need any medication. Unless if it is severe, then it will be something else. So there is also pressure on the caput pressure on the chest helps clear the lungs of the fluids. So as the fetus is feeling those contractions, the contractions will squeeze the chest, and as a result the fluid that was in the lungs will be cleared off, and the chest will remain clear, and the lungs can now be ready for breathing. The maternal danger signs and the fetal heart rate. Maternal danger signs. There is raising or falling of the BP of the mother. This is the maternal danger sign. Once you detect this, please you need to call for help. Then abnormal pulse of the mother, inadequate or prolonged contractions, and then pathologic retraction ring. The retraction ring is that kind of depression that happens around the umbilicus of the mother. But in some cases, it can be because the bladder is full. But it if that depression happens when the bladder is empty, you have palpated the bladder is empty, then that is a pathological retraction ring, and it has to be you need to act immediately so that the mother's life and the one of the baby is saved. Also, let us look at the fetal heart rate. So the baseline rate is 120 to 160 beats per minute. This is what we consider as normal. So once it becomes lower than 120 beats per minute, or if it is higher than 160 beats per minute, then there is a problem. Then early deceleration and acceleration, these ones we have already talked about them. Abnormal fetal heart rate and the patterns, fetal heart rate patterns, that is the tachycardia when it goes beyond 160. Then you need to take action. Causes can be mild fetal hypoxia or maternal fever. So if it is between 161 to 180, then you need to take action. Abnormal fetal heart rate patterns as a continuation. Which nursing care do we give? We need to monitor the mother, the maternal vital signs to make sure that they are within normal signs. That is the temperature, the blood pressure, the respiratory rate, then the pulse. We need to monitor them. Then we also need to change the maternal position. Then we need to do close monitoring of the fetal heart rate. Then bradycardia, that is between 100 to 119. This means that the heart rate is now low, and one of the causes can be congenital heart disease. Which nursing care do we give? We change the maternal position to make sure to find out whether it can improve. Then administer oxygen to the mother and prepare for immediate delivery. If she is in second stage, we deliver immediately. If not, then she has to go for cesarean section because this is a very bad sign. Then late deceleration definition. Her fetal heart rate decreases during UC, and that is the uterus contractions, and does not return to normal after the end of the same contraction. The causes can be uteroplacental insufficiency. So the nursing care that we can give, we correct the causes, and this can be corrected through spine. If it is supine hypotension or uterine hyperactivity, we figure out and try to correct them. Then administer oxygen to the mother. Then another one is variable deceleration. By definition, this is the deceleration occurring at unpredictable times during uterus contraction. For instance, this can, for instance, can be due to cord compression. So the nursing care we give here is we change the maternal position, prepare for immediate delivery if the pattern warrants it, that we provide to the mother with abnormal fetal heart rate patterns. We encourage birth imminence. If she is in second stage and we can be able to deliver, we can give episiotomy and make sure we deliver the baby immediately. But we need to first determine the signs we detect. Is there imminent labor? So the signs can be sitting on one buttock, bearing down or grunting with the contractions. These are the things that can show that the mother is in second stage and will deliver soon. Then we instruct the patient to pant with the contractions to make sure that she delivers. Then fetal status assessment, we assess the fetal heartbeat, the fetal eye presentations, attitude, station, and the position, as we have talked about this before. We do also risk assessment. For instance, we assess for ruptured membranes. This is referred to as nitrazine test, or then we also assess, then we need to take a decision to make sure that the baby is delivered immediately. Then maternal status assessment, we do the vital tests of the vital signs of the mother, that is the BP, pulse, respiration, and the BP, pulse, respiration, and yeah, I think basically those are the ones that we do at the beginning to make sure that the mother is well. So in addition, also we do the temperature is also part of the vital signs. So that marks the end of today's lecture. Thank you for listening. Hello.